Well, good morning, everybody. Welcome to Geriatric Grand Rounds. A few announcements before we start today. So our next Grand Rounds is November 19th. Our presenter will be Dr. Jennifer Stevens-Lapsley, who's the professor and director of Rehab Science PhD program here. Our next journal club will be November 12th, and our presenters will be Dr. Megan Goss and Dr. Jeff Wallace, so please join for that. Other announcements, there is no division meeting, but there is the fellowship ranking meeting after Grand Rounds today, so you should have a Zoom invitation for that meeting, those of you who are participating. Following Grand Rounds today, you will receive an email with a link to a recording of the presentation and a copy of the slides, and it will also include a link to an online evaluation, so if you could please take a moment to fill that out, that would be really helpful. Feel free to submit questions via the chat box anytime during the presentation. We may be able to answer some of those as we go along, or else have time for those at the end. So I'm very pleased to introduce our speaker this morning, Dr. Laura Scherer. Dr. Scherer is an assistant professor in the School of Medicine, affiliated with the D2B Data to Value Initiative, as well as Accords, COIN, and the Division of Cardiology. She's a social and decision-making psychologist and has spent the past 10 years applying that background to medical decision-making. She has, published extensively in top psychology and medical journals, and her goal is to leverage behavioral science to improve shared decision-making and communication of evidence-based medicine. I think this is going to be a really nice follow-up to Dr. Ubel's presentation last week. So please join me in welcoming Dr. Scherer.
Thank you. So can I get started?
Mm-hmm.
All right, great. Yeah, and full disclosure, Dr. Ubel was a sort of informal postdoc mentor of mine. So we go back quite a long way at this point. I'm going to hide all of your lovely faces here so you don't have to look at them while I'm talking. So today I've chosen to talk to you a little bit about medical maximizing, minimizing framework, which we think of now as a framework for understanding patient values and preferences for healthcare. I'm going to tell you a little bit about what it is, the work that we've done to establish this as a unique individual differences that most people have, and what it can potentially mean for clinical care and eliciting patient values. So let me hold on just a second. There we go. All right. So the first thing that I want to call out in this talk is the idea, the general idea, which is I'm sure familiar to all of you, that patients do play a major role in medical decision-making. So when I tell people that as a behavioral scientist, I study medical decision-making, they often think that I'm studying physicians and how they make medical decisions. And I think that's because culturally we think of clinical interactions as being primarily clinician-driven. And to a large extent they are. Obviously, clinicians are the ones who are diagnosing illness, offering treatments, and medical advice. At the same time, though, patients contribute quite a lot to this interaction. So the first medical decision that they make is to seek medical attention, go to the doctor's office and seek advice for whatever problem they're having. Then after the clinical encounter, they make decisions about whether or not to follow the advice that they've been given. So patients can play an important role in the healthcare that they ultimately receive. And then of course we have shared decision-making, which is an important interest of mine. And this is described sometimes as the meeting of two experts. It's when the doctor and the patient work together to make a decision based on the treatment decision at hand and the patient's values and preferences. So there are a lot of different ways in which patients can guide the care that they receive. So now I want to segue somewhat to imagining or giving you an example of how patients guide their care in pretty profound ways sometimes. So I want you to imagine two different people who are the same. This is completely hypothetical, just so we're all clear on that. They're the same in almost every respect. They're the same age, they have the same health insurance, they have the same income, they have the same health problems. And one of the health problems that both of them, these two hypothetical, virtually identical people are experiencing right now is that they are both suffering from pretty chronic heartburn that is disrupting their quality of life. But then they differ in one very important way. So there's their heartburn. One of them decides that these symptoms are worth it to go to a doctor. So they go to their doctor and they get an antacid prescription. And along the way, they also get a blood draw. So they end up taking one prescription. And as a part of that blood draw, it's also found that they have high cholesterol, which their doctor decides to control with a statin. And then for the sake of this example, let's say that their doctors also decided to give them a PSA test for prostate cancer, so routine PSA test. And it looks like their PSA level is high, and so they end up getting some additional testing to see if they have prostate cancer. So this person ends up getting a lot of care because they went to the doctor to seek out a solution to their problem of heartburn. The other one avoids the doctor. And they decide, I'm going to try to deal with this problem by focusing on my diet to see if I can relieve these symptoms somewhat. So they don't get any prescriptions, they don't go to the doctor, and now they're managing this on their own. So I want us to think for a minute who's better off. On one hand, you have the person who went to the doctor. They received antacid medications, which may help them in the short term. So they're going to probably have greater resolution of their symptoms in the short term. There's a slight chance of harm when you use these particular medications, PPIs that they've been prescribed in the long term, but maybe they won't use them in the long term. This person does benefit because they received a statin to reduce their chance of a heart attack. They also received PSA screening, and now they're getting follow-up testing and potentially treatment that may have a non-negligible chance of harm and a questionable benefit, as I'm sure many of you are familiar with the controversy around PSA screening. So it seems net positive. Now, what about the person who decided to try to control these symptoms with their diet? Well, they're still experiencing symptoms, which maybe are manageable at this point because they've changed their diet a bit. They did miss the chance to get on a statin, which is not necessarily a good thing, but they're also avoiding the potential harm from the antacid medications and the results of the PSA screening test. So I think that some people might say the person who decided to go to the doctor and receive these treatments is better off. Other people might say, well, it's not so bad. The person on the right-hand side potentially avoided the harm of additional treatment, even though they're missing out on certain benefits. So that's my hypothetical example. Now I want to move to real life, where I'm going to tell you the story of Cliff and Don, which you may have heard of from Dan Matlock. Whoops, I meant for Dan's face to come up first here. So you all know Dan, and this story, which I find pretty profound, can be entirely attributed to his work on LVADs and LVAD decision-making and the development of his decision aid. So when I give this talk to a non-clinical audience, I often have to go into some detail about what an LVAD is. For you all, I'm going to assume that you know what this is and you know pretty much the benefits and the harms. And so I'm going to just briefly skip over that part. So the benefits of the LVAD obviously are that people are less likely to die of heart failure. The harms of an LVAD are an increased chance of stroke, a serious device infection, and having a serious bleed that may require medical attention. And of course, you have to have a device placed in your body for the rest of your life that requires electricity. So there are significant patient burdens to receiving an LVAD in patients with heart failure who are at a very high risk of dying. So there are benefits and risks. The story or the contrast between Cliff and Don, though, is really profound and interesting. They made very different decisions when it came to getting an LVAD. Cliff, who's pictured at the top, decided to get an LVAD. And he got an LVAD in 2011, and he is still alive. He's, in fact, there was recently an article written about him as being the longest lived person in Colorado with an LVAD. He's had a very high quality of life with an LVAD, so he reports very few complications. And he was very gung-ho about getting an LVAD. He was very enthusiastic about it and has been blessed with 9 additional years of life. Don, by contrast, really didn't want to get an LVAD. So in spite of the fact that these two men had very similar lives, demographically similar, the same health problem, Don really didn't want to get an LVAD, and he adamantly refused it. He even wrote a letter explaining how he was feeling pressured to get one, and he died within a year. Very different health outcomes between these two men, very different preferences between these two men, despite many, many similarities. And so I think the contrast between Cliff and Don begs the question, why is it that two people who are so similar in so many respects make such very different decisions about their health that had incredibly important consequences for them? And one potential answer to that question is what I'm going to talk about today, which is a proposal about core patient values. Now, I didn't come up with this idea on my own. In fact, when I was a postdoc at the University of Michigan, a book came out called Your Medical Mind by Jerome Groopman and Pamela Hartzband, pictured here. And they proposed in this book, and the book was based on medical case studies, they proposed that every single one of us has an individual approach to weighing the risks and benefits of medical treatments. And they said that this comes down to a few core traits. They said some people are maximalists and want to do everything, and other people are minimalists and want to avoid healthcare as much as possible. They also said that some people like natural treatment and other people are more technology enthusiasts and want the latest and greatest intervention. For the sake of this talk, I'm going to talk about the maximizer, minimizer construct that they introduced in this book and what we've done with it since the publication of this book. So by way of introducing the maximizing, minimizing constructs, I'm going to read a couple passages to you. And this works fairly well with a non-clinical audience, but clinicians also have these preferences. And so I do want to think when it comes to your own health and health care, not necessarily how you treat patients, but when it comes to your health, which one of these passages describes you best? So here's the first one. I prefer active medical interventions, being proactive about my health. I like doing things that might positively affect my health, like potentially taking medicines that are prescribed, different kinds of remedies, vitamins. If there's a health intervention that can be had to improve my health, I'll probably want to do it. Versus this. If given the option, I would prefer to not take medicines or get tests or medical interventions. It's not necessarily the case that I distrust doctors, and obviously that's going to be true in this group. It's just that I prefer to watch and wait until it's clear that medical intervention is necessary. And I go by the saying, if it isn't broken, don't fix it. So now, obviously, it may be the case that neither of those passages describes you perfectly, but think for a minute about which one describes you best. If you think that the first passage describes you best, then you are more of a medical maximizer. You want to go out and do proactive medical things for your health. Whereas the second paragraph describes a medical minimizer who is trying to avoid healthcare unless it's completely necessary. Now, Groopman and Hartzband proposed maximizing and minimizing as a core value that many people have. So maximizers, they're not anxious about their health, but they do just like going to the doctor and doing positive and proactive things for their health. And minimizers are not necessarily afraid of medicine or doctors. They just want help. They just only want health care that they see as being completely necessary. Groopman and Hartzband also predicted something interesting. I told you that they also had that construct of naturalists versus technology enthusiasts. And they said, well, these are different things. That you might think that a minimizer is going to be more of a naturalist. So that's this quadrant here. And then that would be a defining feature of a minimizer. They're people who are seeking out alternative natural healing. But Groopman and Hartzband actually saw these things as different. They said, you can be a naturalist maximizer. You are just maximizing your approach to medicine in a more natural homeopathic healing kind of way. You might also think intuitively that maximizers are technology enthusiasts, but again, Groopman and Hartzband said, no, that's not necessarily the case. Sorry, I was not explaining that correctly. What I meant to say was that maximizers are often thought to be people who are technology enthusiasts and want the latest and greatest, but that's not necessarily the case. And then you have minimizers who might be more technology enthusiasts. They don't necessarily want to go for natural healing. They would prefer standard Western medicine. So my research team at the University of Michigan, and me in particular, thought that this idea of maximizing and minimizing, which we were already toying with at the time in other kinds of research, was a potentially useful construct and worth pursuing with more research and more brainstorming. And the reason why we thought it was useful is that if this is a stable, general, and unique preference dimension, it could potentially reveal patterns of over and underutilization within and across patients. It could potentially help to explain how people respond to medical information and could be used for tailoring to try to be more persuasive to get people to do evidence-based medicine. And it could potentially be used in shared decision-making to facilitate patient-physician communication about the patient's core values. So with that, we decided, well, there's no measure to capture this construct. We actually don't have any way of determining whether a person is a medical maximizer or a minimizer. And in fact, we don't necessarily know at this point, way back when Groupman and Hartspan's book came out, we don't necessarily know that this is different from other things that we already know about, like hypochondriasis. Maybe maximizers are just hypochondriacs, and that's pretty much explains the difference. So we went through the long and arduous process of developing a scale, a validated scale, to measure this individual difference. And these are the questions that ultimately came out in our analyses as being important to measure medical maximizing and minimizing. Not going to read them all, but just a couple. It's important to treat disease even when it does not make a difference in survival. Doing everything to fight illness is always the right choice. So people who tend to agree with those items, we call more medical maximizing. If you disagree strongly with those items, then you're more of a minimizer. And what we do with the scale is we have people agree or disagree to each one of these items on a 7-point scale, and then we average their responses. And this is just a figure that shows the distribution of maximizing, minimizing scores in one of our early samples. And as you can see, it's really well normally distributed about around the center point of the scale. So you have a lot of people who don't have maximizing or minimizing preferences, not strongly one way or another, but you do have people who are more out in these tails and they have strong maximizing, minimizing preferences. The reason why I show you this also is just to display that this is not a dichotomous, people fall into one category or another necessarily. There are people in the middle and it's a distribution. So next I'm going to tell you a little bit about our thinking in developing this maximizing, minimizing construct in medicine. So the first question that we ask ourselves is whether or not this is really a unique characteristic and different from other characteristics that we already know about. And this is essentially an exercise in identifying discriminant validity. We ask, are maximizers the same as people who are hypochondriacs? And these are correlation coefficients that I'm showing you on the right-hand side. They're actually a few different facets of hypochondriasis. There's affective, so these are people who worry about their health. There is behavioral, so these are people who behave in ways to address health problems a lot, which you would obviously think would be pretty well correlated with maximizers. And we do find that that's the case. So you have these fairly, modest, moderate-sized correlations here with worry about health and seeking out health care. Interesting, the perception that a person is sick and then the way they think about being sick aren't really related all that much, or at least are less related to maximizing, minimizing. So with these results, we concluded that maximizing is related to hypochondriasis. Certainly there's some overlap there, but there's not so much overlap that we're measuring exactly the same thing. We also wondered whether or not maximizers are intolerant of uncertainty, so they just need more information in order to gain more certainty about the future. And we did find that maximizing, minimizing is correlated with intolerance of uncertainty, meaning that maximizers tend to be more intolerant of uncertainty. They're seeking more certainty in life, and that might be one reason why they're seeking out healthcare. But again, these two things are not so highly correlated that we're worried that we've developed a duplicate measure. We also asked whether or not minimizers are simply people who have negative beliefs about medicine or doctors. So we measured the belief in medicine scale in one study. And part of that scale is the belief that doctors do harm. And there was zero correlation with our maximizing, minimizing scale, meaning that minimizers are no more likely than maximizers to believe that doctors do harm. Minimizers were slightly more likely, though, to believe that doctors overuse medicine, which kind of makes sense. And then our minimizers, homeopaths or naturalists, we had a number of items to measure this, and there was really no correlation between the average of those natural medicine preferences and minimizing. So in other words, Grubman and Hartzman ultimately were right that you can be a maximizer naturalist and a minimizer naturalist for that matter. So we asked ourselves more questions about what is this maximizing, minimizing construct? What exactly does this mean? And some of the early questions, again, that we asked were whether maximizers were maximizing in their approach to healthcare because they're sicker than minimizers, so they have more health problems to deal with. We also asked whether maybe maximizers have more healthcare access, and that's why they have a maximizing approach, whereas minimizers have less healthcare access, and that's why they have a minimizing approach. And so we measured the SF12 items, quite a few things, and again, these are correlation coefficients that I'm showing you here. And the upshot is that while we have a few statistically significant correlations popping out, the effects are very small, and overall, it looks like there's very little correlation between healthcare status and maximizing or minimizing. And similar with healthcare access, we had some standard measures of healthcare access that were pretty comprehensive. And while there's some statistically significant correlations popping out, again, they're very small, not very important. So it doesn't seem like maximizers or minimizers have more or less access to healthcare. So this really isn't about objective health all that much, doesn't seem to be about access to healthcare, or at least not all that much, which is sort of interesting. I like to show people this demographic correlates slide also because people start asking me questions about, well, are men more maximizing than women or vice versa? What's the correlation with age? So do people become more maximizing or minimizing with age? What about demographics like race? And here, the thing that we consistently find across samples is an association with race. So if you look at whites compared to a few different minority categories, including Hispanic, African American, you find that whites tend to be more minimizing. That negative correlation indicates that whites are more minimizing than other minority racial groups. This correlation with age here, whereas people become more minimizing with greater age, is small and it doesn't always come out in all of our samples. So what does medical maximizing or minimizing predict? So this is a question now moving on from discriminant validity to predictive validity. Does this individual difference predict the things that we would expect it to? And what we've tested so far is healthcare utilization and testing and treatment preferences. And what we did early on is we looked at people's self-reported healthcare utilization and whether this was associated with the maximizing, minimizing trait. And now these are regression coefficients. I'm switching to regression coefficients because now we're looking at the relationship between maximizing and minimizing and these utilization questions, controlling for hypochondriasis, the belief in medicine scale, which I talked to you about, healthcare access, all of those items, and health status. And what we find is just down the line, maximizers are more likely to have been to the doctor in the past year. So from this, we think that the people who are showing up to the clinic are more maximizers. The minimizers simply don't show up as much. Do you go for a yearly checkup even if you're not sick? Maximizers are more likely to do that for reasons you consider to be minor. And then here, maximizers also report taking more medications, having been in the hospital overnight more times, and having more blood draws for medical tests, which the latter three I find to be interesting because oftentimes we think of those outcomes as being things that are driven by their objective health, their health status. What we're showing here is that there may be some preferences that also dictate these outcomes, and that might be because of this, that maximizers are showing up at the doctor more. So what about treatment preferences? We've looked at a lot of different treatment preferences. I'm going to go over these quickly and get into more realistic. These are scenarios that healthy people are responding to. So we asked them, would you want surgery or physical therapy if you had pretty serious back pain? But there's equal effectiveness. Physical therapy takes longer. surgery has risks. And we find that maximizers are more likely to prefer surgery over physical therapy. Maximizers are more likely to want cancer treatment versus watchful waiting for, or surgery versus watchful waiting for cancer treatment. And maximizers are more likely to want continued chemotherapy over palliative care for a terminal cancer. These are hypothetical, but still it's fairly compelling that maximizers can, for all of these very different kinds of medical decisions, are preferring a more aggressive approach to healthcare than minimizers. So recently I was a part of a research team. This is in connection with some of my colleagues at University of Michigan, in which we looked at the role of these maximizing, minimizing preferences in thyroid cancer surveillance. So we surveyed patients, and this was driven by Megan Hamer there at the University of Michigan. We looked at thyroid cancer surveillance. So these are people who are disease-free. They've effectively been cured of their thyroid cancer. Are they coming back for more surveillance appointments and healthcare utilization? And what we found is that relative to minimizers, people with a more maximizing preference tended to have more doctor visits, more neck ultrasounds, more iodine scans, and more additional imaging studies than minimizers. So again, we're finding that even in more of a real life situation, maximizers are seeking out and receiving more healthcare than minimizers. Also, and this is a group led by Sarah Hawley, and I wasn't a part of this, but I found it to be really interesting. This is a qualitative study of older women with breast cancer and looking at their preferences for low-value services. It was qualitative interviews. And what they found is that women who identify themselves as being more maximizing in their healthcare approach, they were the ones that wanted more aggressive, low-value breast cancer treatments relative to people who identified themselves as minimizers. In another study, my colleague Stella Kang and I found that in patients who are about to undergo an imaging study, were described what it means to receive an incidental renal finding on a diagnostic imaging test. And waiting in the waiting room, we asked them, would you want to receive more follow-up testing or potentially have this incidental finding removed? And people who identified as being maximizers were more likely to want surgery to remove a suspicious mass relative to minimizers. So they're anticipating, if this were to happen to me, I would be more likely to want to have this thing removed if they're a maximizer. So at this point, we have garnered a lot of evidence that maximizers have just a general approach for wanting and also oftentimes receiving more healthcare than minimizers. But I want to reinforce the idea that we don't think of maximizing or minimizing as being good or bad. We have no judgment here necessarily. It is just an orientation that guides how people think about healthcare and their need for healthcare. Really, it's not better to be a maximizer. It's not better to be a minimizer. And so I just want to make sure that that is all completely clear as I talk about this.
Laura?
Yes.
We have one question that I think might be timely at this point in the presentation, if we can ask it.
Yeah.
So the question is about mental health, and wondering if you've looked at these maximizing, minimizing constructs as they relate to treatment and care for mental health versus only physical health.
No, we have not. We have not looked at mental health. I would actually be interested in that, and I guess an obvious prediction is that people will seek out more care for less serious mental health issues if they're a maximizer relative to a minimizer who may not seek out care at all for mental health issues or may be at risk of that. Yeah, absolutely. That's interesting.
Thank you.
Yeah. Yep. So sorry, I lost my train of thought for a minute, but that was a really good question and I'm glad it was asked. So the next thing that we asked after making it clear here that we don't see maximizing or minimizing as being either good or bad. This is just an orientation. we nonetheless wanted to know whether this maximizing, minimizing orientation puts people at risk of certain negative outcomes. In particular, we thought probably minimizers are at risk of avoiding high benefit care, like colorectal cancer screening at age 60. Whereas maximizers may be at risk of seeking low benefit care. So for example, and I think this is sort of an extreme example, but nonetheless it exists, a full body CT scan on a completely healthy person. You're probably familiar that there are boutique clinics that will offer this for people who pay cash. So is a maximizer more at risk of receiving something like this that, you know, very few, if any, medical experts would recommend on a routine basis? So we conducted a survey of, just a general survey of 785 US adults, and we asked them to express preferences to receive or not receive a number of high versus low benefit interventions. So we came up with 8 examples of high benefit medical interventions, like the flu vaccine and colorectal cancer screening, so things that are recommended. And we came up, using the Choosing Wisely campaign examples, we came up with 10 examples of low benefit interventions, like full body CT scan on a healthy person, or receiving an MRI for a minor head injury. And just to give you a really clear picture of what we did in this study, we gave them a scenario that was about this long. So imagine you're 40 years old, you fell and you hit your head, you have classic symptoms of a concussion, but no other symptoms that indicate you've done more serious damage, like a cracked skull. And you're not taking any medications that would increase your risk of bleeding, but you could get a brain scan just to be sure. Would you want to go to the ER and get a CT scan? And then we had them pull a slider scale. So to the right is I definitely would go and get treatment or seek treatment for this problem, depending on the scenario. And to the left is I wouldn't do it. And now I'm going to commit the cardinal sin of showing you too much data on a slide, but I'm actually doing it for a reason. So each one of the rows here is an outcome measure. All of the data you see are regression, are the results from regression. And what we did is for each one of these outcomes, so for example, people's preferences for a flu vaccine on the first line, we included affective hypochondriasis, that's MIHT affect, health risk perceptions, health status, race, age, sex, education, whether they work in a medical field, all those things go into regression, along with a maximizing, minimizing scale to predict a person's willingness to get a flu vaccine, their willingness to get a colonoscopy, medicating high blood pressure, et cetera. These are all the high benefit interventions. And the thing that I think comes out visually on the slide is that the one thing that is consistently predicting their preferences for all of these high benefit interventions is the maximizer minimizer scale. Maximizers are more likely to want to get these high benefit interventions than minimizers. Here are the low benefit interventions. And again, we have MRI for low back pain, full body CT, surgery for plantar fasciitis, etc. And again, visually, you can see that the thing coming out is that the MMS is the most consistent and strongest predictor of all of these low benefit interventions. And again, we find that maximizers are more likely to want each one of these interventions than minimizers, even when controlling for all of these other things. In terms of the variance explained by the maximizing, minimizing scale, for high benefit care, the maximizing, minimizing scale is explaining 11%, which is not a huge amount of variance explained, except in behavioral science, we actually make a big deal out of this. But it explains about 11% of the variance in preferences for high benefit care. All those other combined covariates explained much less, about half that amount of variance. Turning over to low benefit care, we have maximizing, minimizing explaining almost 30% of the variance in preferences for low benefit care. And again, all those other combined covariates are explaining about half of that amount of variance. So the MMS is actually contributing quite a bit of explanatory power for why, or how people prefer both high and low benefit care. I did want to interpret this for a minute because you might already be wondering, why is it that maximizing, minimizing explain preferences for low benefit care better than for high benefit care? And our working hypothesis is going back to what Groupman and Hartspan originally said about what it means to be a maximizer or minimizer. And that is, if something appears high benefit, both a minimizing patient and a maximizing patient are probably going to want it, because minimizers, they don't want healthcare that's unnecessary. But if something is clearly necessary, they do tend to want it. So they tend to want high benefit care. What they don't want is care that looks like it might not be so beneficial. If something appears low benefit, minimizers tend to reject it, maximizers tend to want it still. So, and of course, this particular finding could have been driven by the specific scenarios that we chose and how they were written, and so there is that big limitation out there still. Nonetheless, this is a working hypothesis that is consistent with Groupman and Hartspan's original conceptualization of maximizing and minimizing. So next I want to tell you briefly about how maximizers and minimizers react differently to evidence, and we explored this in the context of prostate cancer screening, so PSA screening. And I just want to watch my time here. So we got a sample of quite a few men. I think we had about, I'm forgetting exactly the number of men, I think it was about 1,000. But we gave them information about PSA screening for prostate cancer. Our first baseline description of the test is basically, this is a blood test that is part of screening for prostate cancer. After telling them that, 77% of men said, I would want to get this test. Then we gave them a lot of information, quantitative and actually qualitative information here, so that's kind of a mislabel. We told them about cancer death with and without screening. We told them about the rates of false positives or the rate of overdiagnosis for this test. We gave them 3 stories about men who had been harmed by this test just to sort of overdo it on the negative side. And then we said, would you want to get this test? And not surprisingly, only 46% of men said yes. Not surprising because we just gave them a bunch of negative information. But the more interesting thing is that how this change in preferences split by maximizing versus minimizing. Before they received any information, minimizers wanted the test less than maximizers, who are here. But you can see still a majority of minimizers wanted to receive PSA screening. After all of that information, you see that maximizers have only dropped by about 10 percentage points. So they are still the vast majority of them are wanting screening even after all of that negative information. Whereas minimizers drop from over 60% to under 20% of them wanting to receive a PSA test. So really, minimizers seem to be much more sensitive to negative information about screening in this case. So I want to give you a 3/4 time summary, about 3/4 of the way through this talk. What we have established at this point in this talk and just generally in the literature is that maximizing and minimizing seems to be a generalized orientation towards healthcare. As Groupman and Hartspan hypothesize, it seems to be a core value. It underlies many preferences in medical decisions and the way that people approach their healthcare. It predicts quite a lot of stuff. It predicts preferences for many different types of healthcare, which is interesting because you would think that people form preferences uniquely for each medical situation that they are in, but it seems like there's actually a broader orientation that is underlying their approach. It predicts who's likely to over and underutilize medical care. And it also, I didn't talk about this actually in this talk, I took it out, but it does also predict who tends to be resistant to certain recommendations, guidelines, and evidence. I guess I did talk about that in reference to PSA screening. But we have some more evidence about people's specific reactions to guidelines. Maximizers tend to be resistant to guidelines that dial back the intensity of care. Like, for example, guidelines to do less PSA screening. At about this point, when I describe medical maximizing and minimizing to people, they started to ask me questions like, what is this really? What does it mean to be a maximizer or minimizer? And I want to answer this question in 2 ways. One is, how exactly do we understand what this orientation is? The way that I understand it at this point is that it's fundamentally an individual difference in risk perception. That you have risks and benefits of medical treatment, and maximizers and minimizers weigh these risks and benefits differently. Whereas maximizers tend to be more sensitive to the risk of not taking medical action. So this would be an error of omission in psychology speak. Minimizers tend to be more sensitive to the risk of taking medical action. So they're more sensitive to things like potential side effects, complications, the inconvenience, and the cost. So they tend to be more sensitive to errors of commission, again, in psychology speak. And sorry for my dog barking in the background. I want to answer this question in a slightly different way, though, because this is also a question that I get pretty frequently. What causes people to be one way or another? What causes a person to be maximizer or a minimizer? And in answer to that question, I would say, I don't know. I have a picture of a little girl shrugging. I have no idea. Actually, it's not the case that I have no idea. It's a case that we have not completely researched that question yet and really established what is it that's causing people to be this way. When people ask me the question of, how do people form these attitudes, I start to think about other individual differences that are multiply determined, like political orientation, as a timely comparison. When we think about political orientation and where people get their, liberal orientation versus conservative orientation, we think, well, it's probably determined by their life experiences, their family and cultural environment, their personality, and also their political knowledge and expectations, and what kinds of, political outcomes they want to see. Maximizing and minimizing is probably similar in that respect, that a person has or develops more of a maximizing or minimizing preference based on their life experiences, family, and cultural environment, personality, etc. And also, I will this is a light warning, if you talk about this construct with your patients, like political orientation, people tend to think that their own personal perspective is the best one. And they often think that their perspective is also the only one. So they don't realize that there are other people out there, many people don't realize that there are people out there who have a very different approach to medicine than they do. I want to just briefly tell you a little bit of recent research that we've done looking at scientific reasoning skill and trust in science and how these relate to maximizing and minimizing preferences. We did an exploratory cluster analysis with a data set that was originally collected for another purpose, but I thought that because we had these measures of science, reasoning skill, and trust in science, it would be interesting to see how they map on. And what we did, if you're not used to looking at the results of cluster analysis, have no fear, I have a summary of what this means on the side. Essentially what we find is that when you have a person who is more of a maximizer, that's this little point going off to the right here, maximizers tend to be pretty average in science reasoning, but they're high in science trust. So these may be people who don't have a lot of background in science, but they're putting a lot of trust in it, and they're putting a lot of trust probably in you as a clinician to make a science or evidence-based judgment for them. Minimizers, on the other hand, you might think that they'd be low in science trust. In fact, they are pretty high in science trust, but they're also high in science reasoning. I've come to think of minimizers as people who can be, again, here's them being minimizers. Minimizers who tend to be a little bit more savvy in their reasoning. They do trust science, but they also are pretty aware of the, or they may be pretty aware of the potential flaws or uncertainties in science, and they may be aware of the flaws and uncertainty in some medical treatments as well. All right, now I'm really getting to the end. What can we do with this knowledge? I think that's an important question whenever we get into these sorts of basic questions about patient preferences. I want to start with the what not to do with this knowledge. Oftentimes when I speak to clinical audiences about maximizing and minimizing, the very first impulse is, great, I can figure out whether or not my patients are a maximizer or a minimizer, and I can use that knowledge to determine what treatments I discuss with them. And my reaction to that as a psychologist and with some, pretty deep knowledge of this individual difference is that that's not an appropriate use of this idea. And the reason why is that there are a lot of factors that determine patients' preferences for care. There's the objective risks and benefits of treatment. So it's not the case that a minimizer would necessarily reject all of the preference-sensitive treatment that you offer them. They're more likely to. but they may not. It's not the case that a maximizer wants to do everything. There are circumstances in which a maximizer will feel that it is not worth the risks of doing a particular intervention. So it is necessary still, even if you're quite sure that you're talking to a very strong maximizing patient or a very strong minimizing patient, it's still important to discuss treatment options in a comprehensive way. Okay, so how can this knowledge be used? What can we do with this maximizing, minimizing construct? I think there are 4 things we can do. We can, at a public health level, tailor health messages to increase the acceptance of guidelines and recommendations when it's important to persuade people to get them on board with guidelines and recommendations. So, for example, we can explore ways of tailoring health messages to optimally communicate to maximizers that, yes, it really is important to maybe, for many people, dial back the intensity of PSA screening on a population level, and that's okay. We can facilitate communication with patients to foster values concordant care. So I see maximizing and minimizing preferences as being pretty broad, general, and a very easy way of kind of framing discussions around doing more versus doing less for patients. In fact, I use this when I talk. I'm not a clinician, obviously, but I use this construct, this idea, when I talk to my doctor about care options. I think that it can potentially help patients to clarify their values and preferences and map those preferences onto their care options. We did a focus group with patients from an oncology clinic, and many of them said after they learned their maximizing or minimizing preference that it very much resonated with them and that they wanted to then use this idea to talk to their doctor about care options. So it can help to clarify that they do have this preference where they may not have had the words for that before. We also think that it can potentially help caregivers to understand their loved one's wishes on a broader level, maybe not at a specific decision by decision level, but as a broader approach to medicine. So with that, I have just a couple final conclusions, some takeaways. Some people want more healthcare and more intensive approaches to healthcare than others. I think that's important, and it's a general preference. It's a core, or another way of saying that is that it's a core value, and it helps people to weigh the risks and benefits of medical care and make medical decisions. And I want to encourage the use of this idea for good. Don't use it to limit discussions or the options that are presented, but do use it, I hope, it will be helpful in using it to foster better discussions and more preference concordant care. Whew, so that's all, and I'm very happy to take any questions that you have.
Thank you. That was a wonderful presentation. Just going to give people a moment to type in any questions that they have. So feel free to use the chat function for that if folks have questions they want to ask.
Should I stop sharing my screen so I can see others, or?
You know, I'm not sure if participants are viewable.
Oh, okay.
I think just panelists are, so.
Okay. And I do welcome your challenging questions, critical comments, anything that you have to offer. I love feedback of any kind.
All right, so a couple of questions here. Let's see. So one question is, what about self-efficacy and advocacy? Are those modifiable? Whoops, with respect, I've lost the question here.
Oh, sorry. Self-efficacy
and advocacy.
Uh-huh.
Are those modifiable with respect to minimizer, maximizer status?
Are they modifiable? So I guess the first question I have is, are they related to each other? So is a maximizer or minimizer more or less likely to advocate for themselves? And then are they modifiable? I don't completely understand that question exactly. I would say, well, I'll answer the first question that the question itself did raise for me, I actually don't know if advocacy or self-efficacy are related to maximizing or minimizing. I would actually think that they are orthogonal constructs in the sense that a minimizer might very strongly advocate that they want less intensive approaches to healthcare. And a maximizer might do the same for their more intensive approaches to healthcare. Yeah, whether or not any of these are modifiable, I think there are a lot of deep questions about whether maximizing, minimizing orientation is modifiable, and I don't know about advocacy and efficacy.
Okay.
Actually,
yeah, another question. So this person says, as a minimizer, I favor using this approach to help maximizers avoid low-value care. Do you think we should have more public service announcements of things to avoid? So we have plenty of public service announcements to do things like cancer screenings and less regarding things not to do. Thanks and go blue, it says. Like,
great.
yes, that's from.
And I would say that as a minimizer myself, and wanting to communicate to maximizers, that sometimes it is okay to do less and to take less aggressive approaches to healthcare. I think that it could be helpful for maximizers, but also on a population level, to help people understand and think about the risks and benefits of treatment. And I think that many patients, they just don't even they assume that the care that they're receiving is definitely 100% chance going to help them. The idea of discussing risks and benefits can be sort of foreign to certain people, even though once you start discussing the risks and benefits, then they sort of come out on, well, I would prefer to do more, I would prefer to do less. I think that public health messages could probably just generally create greater awareness of the nuances of medical care. If we could develop messages that were specifically designed to resonate with maximizers, that would be probably, I think, interesting and potentially useful.
Thanks. Another question is, might insurance companies use this information in estimating utilization?
Yes. Insurance companies using this is, I'm not sure how an insurance company would use this. I worry about how insurance companies might use this construct. I think that it could certainly help them to understand who the utilizers are in their patient population, in their insured population, and the extent to which their utilization is being driven by those underlying preferences. I don't know what they would then choose to do with that information, and it does worry me a bit, but and I guess the reason why it worries me, why does it worry me? It worries me because I would be concerned that they start to do pricing based on preferences. Does that, or I'm because it's sort of a black box for me. I think here's really the thing. It's a black box to me how insurance companies would use this information, and I'm worried that they would use it for not completely patient-centered, in not completely patient-centered ways. Perhaps that's unfounded.
And then a question about stigma. So wondering how this relates to more high stigma treatment, for example, such as HIV diagnosis or treatment.
Right, because stigma can determine healthcare seeking as well. I think that might be the thrust of the question. So there are a lot of different factors that might cause a patient to seek medical attention for a health problem. There's access, there's extent of symptoms, there's perceptions of risks and benefits, and how maximizing and minimizing causes people to weigh those. And then there's stigma, and the stigma of seeking healthcare for particular health problems. I think that all of those things are feeding into why and under what circumstances a patient would show up at clinic. And stigma, I would guess, would be different, orthogonal to medical maximizing, minimizing. So a maximizer might not seek treatment because of stigma.
Any other questions from participants? We have a few more minutes here.
These are really thoughtful questions, and I particularly want to do a little bit more thinking about the insurance question as well.
Laura, is there any indication that people's preferences or where they fall on that minimizer maximizer scale changes over their lifespan?
You know, there's only some anecdotal evidence. I'll tell you two things that might be interesting. One is in US samples, I did sort of skirt by this issue a bit. In US samples, we tend to find a negative correlation between maximizing, minimizing, and age. It's small, but what it indicates is that among the samples we've collected in the US, older adults tend to be more minimizing than younger adults, which kind of makes sense because a younger adult might see more benefit to seeking out healthcare because they're younger, they have longer to live, and healthcare problems seem more threatening. Although the direction of that correlation was reversed and statistically significant in a Japanese sample. So there was a Japanese group who approached me and they said, we want to develop your scale for our, translate it. And they found the reverse association in their population that they surveyed. The second way that I'll answer that question is that we did at one point collect data on childhood cancer survivors and compared them to a matched sample of young adults who had not had childhood cancer. We had predicted that people who had had a serious past health problem like childhood cancer would be more maximizing. And we actually found no difference between our matched samples. That study was flawed in a few different ways. It was very difficult to match people, as you might imagine, but at the same time, it does suggest that in terms of being influenced by in terms of your preferences developing because of a very profound past health experience, it didn't seem to matter very much. And there's still a lot of variation in preferences within those two groups.
Thank you. All right, well, we're about at the end of the hour. I don't see any more questions coming in. So I'll just thank you again. This was a really, really wonderful presentation and such a nice.
Great, and feel free to reach out to me with more questions or if you're interested in talking about this more.
Okay, thank you so much. And reminder for those of you participating in the fellowship ranking, hop on that meeting and look in your email for a link to today's presentation as well as the evaluation. So thanks again, and we'll see you next time.